So to continue our discussion a while ago, so if the patient is confined to a hospital and then he or she developed pneumonia, then you can think of organisms such as Pseudomonas, especially if the patient is intubated. You can also consider Klebsiella, E. coli, or Enterobacter. When we think of the pathogenesis, we can have bacterial pneumonia and then viral pneumonia. The clinical manifestations of pneumonia, especially the typical pneumonia, would be fever, chills, pleuritic chest pain, productive coughing. As for the atypical pneumonia, we'll have gradual onset and then non-productive cough and then low-grade fever. These patients, that's why it's also called walking pneumonia, because even if the radiograph imaging of the lungs of this patient is actually the ones that you worry about, these patients, you will still see them walking around, playing around, and they do not look like they are sick. As for the clinical manifestations of viral pneumonia, usually it is preceded by an upper respiratory tract infection, and then the fever is low grade, and then the most consistent finding would be tachypnea. However, in some cases, you can hear crackles and wheezing, and usually it's bilateral. As for the bacterial pneumonia, it's acute onset of chills and older children who have upper respiratory tract infection. So they look sicker, they look more toxic than a patient who has viral pneumonia. So they will have high grade fever, and then um, the ones who have bacterial pneumonia will have more localized findings. So, for example, if the patient have bacterial pneumonia and it is localized to one side, you can have dullness to percussion on that affected side, because maybe that affected side is the only side which has the infiltrates. As for the other types of pneumonia, some etiologic agents can be caused by, which is not written here, but I'll just say, so you can just pause and write if you like to take note. So for the chlamydia trachomatis, usually the presentation is the patient has no fever or wheezing compared to the respiratory syncytial viruses. And then, of course, the age group is very important. The chlamydia trachomatis is considered if the patient is 1 to 3 months of age. So in younger children, you can consider chlamydia, especially if the patient has conjunctivitis at birth, and this conjunctivitis can be disseminated and can become and can present as a respiratory illness. And one characteristic manifestation of an infection with chlamydia trachomatis is the staccato cough. So how does it present? It's like it's like it's like that. So if you have chlamydia trachomatis, you can look for the eosinophils on peripheral blood smear. That's how you diagnose for chlamydia trachomatis. Another one, the chlamydia pneumoniae. It's somewhat difficult to establish because you cannot distinguish it from Mycoplasma, especially if you're only having the impression in terms of your clinical findings. But findings can be, you will have findings that are similar with atypical pneumonia. Usually you will have constitutional findings of headache and malaise and non-productive cough, low-grade fever, and usually it's an insidious onset. Another one would be the Mycoplasma pneumoniae. It causes bronchopneumonia, and then it's also insidious, just like the chlamydia pneumoniae, and you will also have constitutional symptoms like persistence of cough. And since persistent coughing, eventually the pediatric patient will present with hoarseness, and then this hoarseness worsens in about 2 weeks and then improves. The most common finding in Mycoplasma pneumoniae is the RALS. And how do you diagnose? It's through the Mycoplasma IgM titer. So it sounds like a Sounds like a test question, right? As for the physical exams, this is a nice table of respiratory rates indicating the tachypnea in children. So if your pediatric patient is about 2 months to 12 months, especially if you record the RR more than 50, then you can say that the patient has tachypnea. For 1 year to 5-year-old, more than 40, it's already an increased respiratory rate. And then if the patient is more than 5 years of age, an RR of more than 30 breaths per minute is an indication of tachypnea. One important consideration is if the pediatric patient does not have fever or any symptom of respiratory distress. Like for example, the only complaint is cough, and then the patient does not have fever. And then when you look at the age of the patient and then you get the respiratory rate, it's normal, then probably the patient has a different illness, not necessarily pneumonia. The extrapulmonary signs like skin infections suggest other etiologic organism. Like if you're considering skin infections, like what I said on the first part, you consider Staph aureus, and for otitis media, you can consider Strep pneumoniae or Haemophilus influenzae. As for the diagnosis of pneumonia, what you need to do is, aside from your history in PE, you have to order chest x-ray. It's usually used or ordered to confirm your diagnosis. And then how do you diagnose pneumonia? If the patient has cough or tachypnea, or if respiratory difficulty, especially if the patient is already having retractions or having increased rate of breathing, or nasal flaring, or abdominal breathing, especially if you see signs of dehydration in aged 3 months to 5 years old, and the patient is severely malnourished under 7 years old, then you can use, or you should use, chest x-ray to confirm your diagnosis. Another one is when the patient is having high-grade fever, like those who have more than 39 degrees temperature, and then those who have increased WBCs at age 3 to 24 months, especially if the patient has no respiratory symptoms. So chest x-ray will determine the area of the affectation and the spread of the pneumonia. So this is a revised risk of classification for pneumonia-related mortality. It's actually just a guideline. If you're from a different part of the world, then usually you will have your own guidelines. So this is a guideline that is given to my country, the Philippines, and it's actually the latest one. So we classify patients according to their clinical manifestations, like if they have dehydration, if they have malnutrition, pallor, respiratory rate, the signs of respiratory failure. So important here that I just highlight is the presence of grunting. So grunting is considered a sign of severe respiratory distress, because if the patient is already, if your pediatric patient is already grunting, then it's actually a sign that the patient is forcefully exhaling or inhaling through a small airway. So beware or be vigilant for patient with grunting. And then another consideration is chest x-ray. It depends on your country. If your country recommends chest x-ray, and especially for those cases when you have HMOs, some of them will require you to have chest x-ray before you will be compensated. So it still depends. So as for the treatment, as for the diagnosis rather, I'll just skip the part of the guideline that was given to us. You can search for your own guidelines in your own country. So for the diagnosis of pneumonia, you can have, sorry for the delay, you can have, of course, chest x-ray will confirm your diagnosis. It will also help you differentiate viral from bacterial, from mycoplasma, because some of these etiologic agents will present differently in your radiologic image. So for viral pneumonia, you will have hyperinflated lungs. You can also have patchy infiltrates, especially if it's bilateral. Think more of viral. And then for pneumococcal pneumonia, you can have confluent lobar consolidation. Another one which is not written here is the mycoplasma, which will have unilateral lobe interstitial infiltrates that, and usually mycoplasma will have will look worse than the x-ray of a mycoplasma will look worse than its presenting symptoms. Another one would be the chlamydia. It will have interstitial or lobar infiltrates just like mycoplasma. And then if on the exam they mention or they show you an x-ray which has pneumatocyl, you have that is, you must think of Staph aureus as the etiologic agent. So that's one of the most commonly tested questions, board exam questions. As for the microbiological diagnosis, so the isolation of your virus or detection of viral antigens, you can have viral culture. If it's viral, you can have viral culture antigen and isolation in respiratory secretions. If it's bacterial, you can isolate the organism in your blood, in your pleural fluid. But usually for bacterial, sputum cultures rather will have no value in children. Why? Because children below 7 years of age will not be able to expectorate. There are some studies which showed that as early as 6 years old, some of the children can already expectorate. But since for most of the books that I've read, it's 7 years old. So if they won't be able to spit out the sputum or spit out sputum that which you can culture, then it's not really helpful. So but there are times when you can culture sputum, especially if the patient is on endotracheal tube. You can do suctioning. So for example, the patient is intubated today, so you do the suctioning today, and then when you do the suctioning today, you can also now culture that specimen. As for the treatment of pneumonia, it depends on the organism. That's why you may or may not have, but some of the countries they usually recommend bacterial culture or viral isolation, so that for example, if one is suspecting bacterial pneumonia, the physician will do empiric treatment for that specific age group. And then for the atypical pneumonia, we'll just have to skip this one and then go straight to the atypical pneumonia. For the atypical pneumonia, any extrapulmonary manifestations like the skin rash here, or any muscle ache, or any GI symptoms, you can think of atypical microorganisms that cause the pneumonia, like Mycoplasma pneumoniae. And then one thing is that they will have minimal PE findings despite the worrisome radiographic changes. And then how do they cause pneumonia? They attach to the respiratory epithelium and then causing ciliary dysmotility. And then of course, if the organisms cannot be cannot get out of the system of, they will eventually cause cellular destruction and will trigger inflammatory response. For Legionella, what's important for Legionella is that it is spread via water droplets. So especially, for example, in the hospital, if the patient is in an air conditioned room, or that which has cooling towers, then you can also consider Legionella as one of the causes. So how do you treat atypical pneumonia? You use macrolides. So that's it for pneumonia. Good luck.